Good day, I'm Espejo, a clinical clerk from Cebu Institute of Medicine. Today I'm gonna demonstrate the steps of endotracheal intubation using improvised materials. For the case scenario, under the supervision of an anesthesiologist, you are tasked to intubate a 42-year-old ASA1 female who was scheduled for elective thyroidectomy. Prior to intubation, do hand hygiene and wear appropriate personal protective equipment. Assess the patient for possible difficult intubation. In doing this, use the mnemonic lemon. Look externally for any facial or neck deformities. Evaluate for the 3-3-2 rule. 3 finger breaths should fit for the mouth opening, 3 finger breaths from the mentum to the hyoid cartilage, and 2 finger breaths from the floor of the mouth to the thyroid cartilage. Check for the Malampati score. Class 3 and 4 suggest possible difficult intubation. Check for obstruction in the oral cavity and the neck, and lastly, for neck mobility. To aid in remembering the materials needed, we use the mnemonic MAIDS, and for monitors pertaining to cardiac monitor and pulse oximeter. A for airway pertaining to endotracheal tube, laryngoscope, stethoscope, and the bag valve mask. Here we use the Macintosh laryngoscope and the 7 to 7.5 mm in diameter ET tube. Make sure that your laryngoscope has a functioning light source. Check the patency of the ET tube cup by inflating it using a syringe. I for IV fluids. D for drugs. And S for suction. The materials can also be remembered by using these other mnemonics: SALT PS, S for suction, A airway, L laryngoscope, T for tube, P for plaster, and S for stethoscope. Position the patient in a sniffing position by placing a towel or pillow under the head and by extending the neck to obtain a good line of vision of the oral, pharyngeal, and laryngeal axis. Suction secretions that may obstruct the patient's airway. Perform a chin lift and jaw thrust maneuver to displace the tongue anteriorly. Pre-oxygenate the patient with 100% O2 for 3 to 5 minutes to allow for O2 reserve. A bag valve mask attached to an O2 source with an airtight seal is used. Hold the mask using the thumb and the index finger, forming a C grip around the mask, pushing it down, and the other 3 fingers under the mandible, pushing it up. Hold the laryngoscope with your left hand and insert the blade in an anterior-inferior direction along the right corner of the mouth and sweep the tongue to the left. Advance the tip of the blade until the glottic opening is visualized. The wrist must be kept in fixed position and the wrist motion avoided to avoid leveraging on the maxillary teeth. Hold the ET tube with your right hand in a pencil grip. Insert the ET tube on the right corner of the mouth and guide the tip toward the glottic opening. Advance further until the cuff is about 3 to 4 centimeters beyond the vocal cords. The ET tube should be about 21 to 22 cm in. Remove the laryngoscope. To secure the ET tube placement, inflate the cuff with 10 cc air using the syringe. Once done, remove the stylet. Attach the bag valve apparatus and auscultate the lungs and epigastrium to check proper placement. In our case scenario, breath sounds is heard louder in the right lung fields compared to the left, suggesting right endobronchial intubation. To address this, deflate the cuff, pull back the ET tube 1 cm, inflate again, and connect to the BV mask and auscultate for equal breath sounds. Repeat as necessary until equal breath sounds are heard. Right endobronchial intubation is common because the right main bronchus is wider, shorter, and has a more vertical angle. After checking proper ET tube placement, anchor the tube at the right side of the mouth using a plaster. You can order for chest X-ray to further evaluate for proper ET tube placement. Thank you for watching.